or the diabetes control and complication trial, which was started in the 80s, around 1984, and continues all the way up to late 1990s to 200. And that was the first data that came out, but the study still continues up to today after very many years. Prof today is going to take us through this presentation of Turner and Noonan syndrome. And we are very happy, Prof, for frontiering to be with us. And we are happy that actually you have agreed to come back and give us another presentation. Thank you, Prof. You can take over.
You're welcome. Welcome, everybody. So let us begin. How do I get this smaller here? Got you. Push it down here. Maybe we can get there perfect. Okay, so let's start. We're going to do Turner syndrome and we're going to do Noonan syndrome. And for some of you, you may know that for a while, Noonan syndrome was called the male Turner syndrome because Turner really is an X chromosome abnormality. So let's start with that, and then we'll move to Noonan syndrome so you can see the comparison. In the United States, we believe that Turner syndrome is about 1 in 2,000 to 1 in 2,500 girls and women. So relatively rare, but not so rare that you should ignore it. And in most general practices in the United States, and most pediatric specialty practices in the United States, there are usually much more people that are being seen. But that would mean that a typical practice in the big cities would have 4 to 5, maybe 8 or 9 or even 10 girls, and something similar in the adult women practice as well. The goal is to make the diagnosis earlier, not to wait until the absence of puberty shows up or that puberty is delayed. Turner syndrome is still underdiagnosed despite the 6 women that were described clinically by Henry Turner and for whom the syndrome is named. The classical syndrome has various genetic components to it, now identified. About 60% of Turners have what's called 45X0, XO. So we're missing the second X chromosome. And then there are a whole host of others. There's a group of another 15% that are mosaics, 45XO and 46XX, a combination. You could have 45XO and 46XY. That's more important to know about because of potential gonadal malignancy in those young women. You could have 45XO and 47 with a triple X, and any combination you really want, 45X, 46XX, 47XXX, etc. 15% with chromosomal mosaicisms. Structural abnormalities, isochromes, partial deletion, ring chromosomes, literally an X chromosome that's partially deleted and in a little circle, 10%. Combinations of mosaic and structural abnormalities, another 10%. And the last one is kind of the other more rare, unusual combinations. And here's what that might look like if you think about what the genetics looks like diagrammatically. You lose a segment of that X chromosome, and you could have breakage. You could have what are called U-type exchanges. You can have acentric fragments that are lost. You can have homologous long arms. Here's a formation of a ring chromosome. Depending on which one of those varieties you're dealing with, you can have a variety of abnormalities besides just short stature and besides just delayed puberty or absent puberty completely. One of the earliest signs, and sometimes in the newborn, may be the initial presenting sign, which is peripheral lymphedema. It's actually quite rare in most newborns. So if you see that in a female, you might want to think about getting a karyotype. About a third of Turner syndromes will have peripheral lymphedema. Tends to improve with age, but that doesn't always go away. We think that the abnormalities of the lymphatic system are actually related to several other congenital anomalies in Turner syndrome. The classical webbed neck, I'll show you some pictures of that in a moment. Just funny ear anomalies, low posterior and upward turning hairline, what is a so-called shield chest where the nipples are spaced a little bit further apart than is commonly seen, and what we call nail dysplasia, funny nails. And again, I'll show you some things here. Here's lymphedema of the actual newborn genitalia in a female. Here's what the web neck might look like in a baby. Side view and back view with redundant skin. The suspicion is that this is a resolved cystic fibroma, like I said, part of the lymphatic syndrome. Here's an example of the low hairline and the upward pattern for the hair. Some bushy eyebrows are sometimes described in Turner syndrome, as you can see here. Here's some examples of the shield chest with widely spaced nipples, two different young girls. And here's kind of what nail dysplasia looks like compared to a typical nail. About 75% of Turner's patients will have nail dysplasia. It can be the toenails, it can be the fingernails, it can be both. It can be not there at all, of course. And funny curvature, smaller than expected nail coverage. Oftentimes, the cardiologists are actually the ones that bring this to attention because there are a bunch of structural abnormalities of the cardiovascular system that may prompt that diagnosis, even in infants. Again, about 33% of Turner syndromes will have some cardiac anomalies. They are most commonly, but not 100%, left-sided anomalies. So you have coarctation or abnormalities of the aorta. You have bicuspid aortic valves. You have aortic atresia itself. And again, any combination of that you want of those things. Here's an example of a diagram of a normal heart on the left and a ductal coarctation. Here's a particular study that showed, again, almost 60% abnormalities. You could have structural abnormalities about 40% of the time, non-structural anomalies like hypertension, conduction defects, mitral valve as opposed to aortic valve abnormalities, peripheral effusion, and all the things I talked about before with the valves, especially on the left-hand side. Here's an example of a young infant girl with cardiomegaly, pulmonary vasculature increased with borderline pulmonary edema, and echocardiograph will tell you where the actual obstruction is and what kind of coexistent lesions is going on. You might have reduced pulses and blood pressure in the legs if the aortic arch is compromised. You can have asymmetric blood pressure in the arms if it's one side of the arch and not the other side of the arch, right versus left. You could later on have some claudication of lower limbs if there's compromise. And of course, cardiac murmurs, either systolic or continuous murmurs. The coarct features generally present after the neonatal period, unless you're suspecting that diagnosis for some other reason. Here's an example of what X-ray looks like with post-stenotic dilatation of the aorta, dilated descending aorta, and the actual coarct as outlined. Bicuspid aortic valves, like I said, about a third of the patients. It can be an isolated anomaly with no functional significance. You could sometimes hear a systolic click when you're listening to the chest, and may progress to more overt aortic stenosis with a harsher systolic murmur. Hypertension, not just in adults, but even in childhood. Increase when there is a cardiac structural problem, or if there's a renal problem, and I'll show you some of the types of anomalies of the kidneys that go along with this. Often the hypertension doesn't have any specific cause found, and so blood pressure should be automatically checked, and perhaps in Turner syndrome, both the right and the left side done together, because it can be asymmetric, right versus left, or both. You can have aortic dissection and aortic rupture, more than 40 patients, generally a little bit older, late teenagers, young adults. The risk factor is prior coarct, bicuspid aortic valve, systemic hypertension, maybe some increased risk with pregnancy, but 10% have no predisposing obvious factor. Here's pictures of the aortic root and the descending aorta. Now, for renal anomalies, this is what the normal anatomy looks like, right? You got adrenal glands sitting on top of the kidney. But in this example, you've got two sets of renal arteries showing up. You can have collecting system abnormalities, especially early, duplications. You could have renal positioning abnormalities, again, relatively early after the baby is born. Horseshoe kidneys, ectopic kidneys in the wrong place, malrotation of the kidney. With pregnancy, the renal vascular abnormalities can become big problems. You have aberrant renal arteries. You can have duplications of the upper renal tract, up to 20% of patients with Turner syndrome. That's a 20-fold increase approximately. So two ureters, double kidneys, pelvic systems. You could have what are called horseshoe kidneys, where they look like they're looped together in the bottom. Again, a 50-fold increase, 1 in 500 in the general population, 1 in 10 of Turner syndrome will have horseshoe kidneys. And the lower poles, like I said, are fused while the kidneys are still in the pelvis. The fused segment usually has normal renal parenchyma, but after fusion, the kidneys can't rise to their normal position, so they're in a funnier position. And then think of any abnormalities of renal vasculature, and you can have them. You can have polar renal arteries, you can have secondary hydronephrosis, you can have inferior vena cava and aortic abnormalities, you can have duplication of renal veins in any combination, like I said. And this is an example of an IVP in a patient with a partial right duplex collecting system. Here's a scan of a horseshoe kidney that you see connected on the bottom. Orthopedics problems, also very common. Knock knees, 40% with a short neck, 40% of Turner syndrome, which is cervical hypoplasia, generally no clinical significance or pretty minor, but it's a cosmetic effect that upsets some people. And here's what it would look like if you showed X-rays of that. Just a shorter neck versus a normal on the right-hand side. Actual scoliosis, instead of 2 to 3% in the general population, in Turner's 10 to 12%. And the general population, the scoliosis often doesn't really show up until the growth spurt in the teenage years, whereas in Turner syndrome, it shows up a little bit earlier, in early childhood. You could have round-shouldered posture, which is common. You can have a significant kyphosis or a mild kyphosis. And of course, this is the standard inspection for scoliosis: forward flexion, view from the side, view from behind. More prominent side is the convex side of the curve. Some non-specific arm and hand abnormalities, cubitus valgus, kind of your arms moving out in a Madelung deformity. Short fourth metacarpal, single palmar crease, and I already told you about nail dysplasia. Here's the carrying angle. The general population, females have a slightly wider angle of 12 degrees compared to males in general, but in Turner's it's 15 to 30 degrees, so more than the rest of the female population, and much more than the boys. Here's the cubitus valgus. Here's what it looks like if the fourth or sometimes the fifth metacarpals are too short. You get a premature fusion of the metacarpal epiphysis, and again, in a third to 40% of patients. And we don't really have a very good specific understanding of all these anomalies genetically, but we know that they cluster together. Congenital dislocation of the hip is also more common, 5 to 10% versus 0.1% in the general population. And it can be an abnormality of the acetabulum, of the femoral head itself, of the joint capsule, of the soft tissues, or any combination. Here's what all the orthopedic evaluations, and once again, if you have a very wise orthopedic person who's evaluating this patient, they might notice that this has got delayed development, delayed puberty. Some of these other abnormalities may become more common, including cardiac abnormalities, like I told you. But this is what all of them look like. And sometimes that's where the referral comes for endocrinology, is from orthopedics, not from cardiology. There are ophthalmologic abnormalities. Some examples that you're looking at here. Widely spaced, a little bit of squinty eyes, a little bit of strabismus, kind of big, almost bulgy eyes. Strabismus in a third, ptosis in 16%, hypertelorism 10%, extra epicanthal folds, and antimongoloid slant, so to speak, and the red color green problem. Some studies have suggested also increase in glaucoma, again, not 100%. So on the left, there's prominent epicanthal folds and telecanthus. On the right, still prominent epicanthal folds with down slanting palpebral fissures. Strabismus. Inward turning esotropia is a little bit more common than exotropia, outward turning. Can start to see that at 6 months to about 7 years. And an asymmetric corneal light reflex may also be present. Ear disorders, recurrent otitis media problems as high as 70 to 100%, with hearing defects in about 50%. Abnormal anatomy of the pharynx and the palate, as well as disturbed relationship between the middle ear and the eustachian tube, are the presumed culprits. And again, you can see that the eustachian tube is a little bit more horizontal. There's poor drainage. It's a little bit shorter than it normally should be. Allows, we think, more microorganisms to enter and infect the middle ear. And all kinds of otitis media with effusion, with infection, with hearing loss, etc. And hearing can be in childhood. It is generally conductive loss in childhood. It could be either conductive or sensory neural or both when you have some hearing deficit. If it's early on, you may have impact on language development, learning, and socialization with the decreased hearing, especially if it's not recognized and attempts at correction don't help you. As soon as you make that diagnosis, you ought to look for all the rest of these things and see what has been missed or not, because lots of them are missed, or lots of them are known but not linked together with Turner's as the underlying diagnosis. And it has to be reevaluated regularly throughout life, not just in kids. You can have a retrognathia or an actual small jaw micrognathia, kind of downward sloping or small, up to 60%. You could have abnormalities of the teeth. The craniofacial changes can be just a short cranial base, underdeveloped facial bones, a high, narrow, or U-shaped palate, many kinds of dental malocclusion, abnormal dental morphology, and an advanced dental age compared to other bone phenomena. The dermatologic findings, again, 6 different ones that we know about: melanocytic nevi, seborrheic dermatitis, keratitis pilaris, dermatitis in general, cutaneous and visceral hemangiomas, and keloid scarring. And let me show you some pictures of those. So here's what nevi look like. 25 to 75% of patients with Turner syndrome, depending on which study, have at least 15 nevi. So it's not very subtle. There have been case reports of melanoma in those nevi. And dysplastic nevi should specifically be followed very closely and looking for changes in color. And here's what keloids look like: exaggerated scars. Intelligence is generally normal, but skewed slightly lower than in the normal population, as you can see in the full-scale IQ shown below. And lower scores in performance compared to verbal tasks. Specific school problems from a parent report, a little bit more than double in Turner syndrome versus a control population of young girls. Here's the mean scores for grade differences compared to the normal in gray, the Turner syndrome scores for everything you can measure there: numerical, fractions, geometry, addition, subtraction, multiplication, division, mental calculations, reasoning, especially difficulties with mathematics. But you can also have generalized hyperactivity, inattention, distractibility, and just slowness. Repeating of grades is common. If you know about the diagnosis, you want to pay attention to the learning issues. Earlier is better than later. There are specific problems with psychosocial adaptation. The young patients may have increased general activity levels and, like I said, difficulty in concentration. The older patients, as they get to be middle school, high school, and further on, can have anxiety, depression, or both of them. They often will feel socially isolated, especially if it was a late diagnosis and there wasn't psychosocial support going on for the family and for the child. They tend to be later to date, less likely to marry, and no evidence of increased risk of psychiatric disorder. Those are all anxiety, depression, social isolation. Endocrine disturbances are several with Turner syndrome. Growth disturbance being one of the more common ones. Also, thyroid disorders, hypothyroidism, but also hyperthyroidism, less likely. They have some insulin secretion, carbohydrate metabolism, insulin resistance kind of issues with diabetes. About 5% of Turner's patients will have overt celiac disease. 40% of those will have concomitant thyroid disease. So the autoimmune aspects of this for thyroid and celiac are important. And inflammatory bowel disease, Crohn's disease, as well as ulcerative colitis in as many as 3%, usually in the late teenage years. And if you look for it, they'll have low levels of vitamin D. That's rather common when anybody starts to look for vitamin D, but even osteopenia or overt osteoporosis can present in Turner syndrome earlier, we think, than the general population, but that hasn't been studied as well. Here's what growth charts look like. So the standard growth chart from 4 European studies with almost 400 patients. Red is the 5th to the 95th percentile of the normal female populations. You'll notice that the Turner's kids tend to be shorter on average, a little bit of overlap in the lowest percentiles of the non-Turner's kids up until about age 8, 9, 10, when they start to drift down, unless you're giving them growth hormone and unless you're giving them estrogen to finish up their puberty, because they're not going to do that all by themselves. I'll show you some studies. They are not overtly growth hormone deficient, but when you treat them early on with growth hormone, they catch up quite nicely into the normal population. But you can see untreated, undiagnosed, they're going to be very, very short. The growth failure begins in utero. It is absolutely significant by mid-gestation and may be picked up if somebody's having an ultrasound exam during pregnancy. The birth length is generally about 2.8 centimeters below mean for female infants. So they're not super short, but they're on the shorter side when they start. And again, you can see kind of where that is when you start from 2 all the way up to 18-ish or so. They're falling further and further away from the general curves as we watch them. So it's hard to understand if you were plotting height and weight as you're supposed to, if you're a general practitioner or a general physician, or even a school nurse or a nurse who's assisting in the clinic. If you actually plot the chart, you'll pick these kids up very, very early because this low height will give you a clue, especially as they're drifting away further on. Any one of those arrows is when you should make the diagnosis. Here's what it looks like if you look at individual dots for Turner's and compare them, very similar to what I just showed you. There are some studies that suggest it's slightly different for the 45XO versus the mosaic versus the complicated chromosomal pattern, but again, not so consistent. Here you can see more and more as you go on in years, 50% below the 5th percentile by 1.5 years of age. Tell me why you shouldn't make that diagnosis, please. 75% below the 5th percentile before 4 years of age. Again, tell me why you shouldn't pick up this early growth failure in all of those karyotypes. There's a little bit more variability with the isochromosomes of the mosaic karyotypes. The height has generally been below the 5th percentile in many studies for 5 years before the Turner syndrome was diagnosed, even though they will have 4 or 6 or 10 different systems involved. If you put that together, that's what it's all about. And here, for instance, is a general female population, 163 centimeter average population. In Turner syndrome, that's 143, 20 centimeter delta. And here's what it looks like in different populations where there are taller versus shorter people. So even in places where there's more tall people in the general population, Holland, Germany, northern Germany especially, Scandinavia, Denmark, Switzerland, Finland, Turner syndrome significantly less. Untreated growth in Turner syndrome is intrauterine growth retardation. There's postnatal growth failure as well in infancy that should be diagnosable. There's slow growth throughout the rest of childhood and adolescence. There's prolonged late, delayed growth because puberty is either absent or totally delayed. Adult height is late to be obtained, early in the 20s. So there's a delayed bone age because of that. And like I said, a 20 centimeter average mean below the general population. Untreated adult height correlates with childhood height with mid-parental height. So if you have shorter parents, that will make it even worse. Multiple international studies over many years with long follow-up now in registries shows that while there's no growth hormone deficiency when I do stimulation testing, when I treat these young girls, and especially younger is better, you get a better recovery, with subcutaneous 0.5 milligrams per kilo per week in nightly divided doses, you increase the annualized height velocity, You increase the predicted final height estimates. No significant different side effects than any other growth hormone treated patients. There are some rare cases of cerebral edema, slipped capital femoral epiphysis, and unmasked hypothyroidism. No clinical deterioration of glucose intolerance, even though there is a tendency for that in general, but growth hormone doesn't make that any worse. And like I said, starting growth hormone early and perhaps delaying the introduction of estrogen replacement, menses, allows the epiphyses to remain open a little bit longer. That's especially important if you're very late to start your growth hormone, but it's true for whenever you start growth hormone. You should have a conversation with the family and with the young child as they're maturing and moving into the middle ages and then the preteen, teenagers about breast development and why you might want to delay that just a little bit to allow the maximum final height. We think that the abnormality is a SHOX gene abnormality that encodes a transcription factor that allows normal chondrogenesis. The target genes are not so well known now, but we're hoping we'll identify those a little bit better along the way, as we're doing with other genetic conditions. So, and the mechanism of action, again, is being studied. Here's some examples that show you what growth hormone actually does in some of the studies. The mean adult height gain, when you started growth hormone treatment at less than 11 years of age, but added estrogen at age 15, as opposed to doing the same thing, starting growth hormone treatment under 11 with estrogen begun a little bit earlier, not as good of a final height gain. And even less if you start your growth hormone less than greater than 11 years of age and add estrogen then a year later. That's the worst of the three outcomes that were studied in this particular study. Here's what it looks like if you look at height velocity achieved, all rather better than the standards, which is the catch-up growth. I told you there's some glucose intolerance, some insulin resistance, up to as high as 15% or a fourfold risk in the Graf-Hold study, lower in the Seibert study. We don't have as specific information about this as we would like to have, and we don't have long-term follow-up, but we think that there is going to be more of the metabolic syndrome and over type 2 diabetes as well. 32%, 40% in some of the specific metabolic studies going on. You get hyperglycemia in response to standard glucose loads. You can sometimes see normal glycemia, but with hyperinsulinemia from the presumed resistance. Some evidence of defect in glucose handling that develops even earlier, and insulin resistance and hyperinsulinemia. No correlation with muscle mass or degree of adiposity. The autoimmune conditions is up to 30% of Turner syndrome patients will have antibodies, Hashimoto's thyroiditis, that increases with age. Overt hypothyroidism in about 10%. There is some association with an isochromosome XQ. And like I said, there's a smaller group that have Graves' disease rather than hypothyroidism. And monitoring specifically TSH and thyroid antibodies at least annually. If you get antibodies and they're staying pretty consistent, you still want to monitor at least an annual TSH, and you want to ask some specific questions about clinical thyroid disorders as you're seeing the patients every single visit and document that in the chart as well. If you've got antibodies that are positive and remaining positive and not changing, you might not, if that's the only abnormality, need to do that quite as often. But again, that's not so well known. But the TSH would screen for those, especially in positives. But you can even show up abnormalities of thyroid function when you had negative antibodies and then they become positive at some point later on. Celiac disease, like I said, is also more common, sometimes with both thyroid conditions and celiac together, sometimes one versus the other. So you ought to screen with transglutaminase or some similar antibody for the celiac problems. May not have any symptoms. It's unclear if specific vitamin D osteopenia and osteoporosis, like I said, is the same or worse than the general population, but taking a dietary history will give you some clue as to how much calcium and vitamin D that person is taking. Taking a family history will likewise give you some clue to the concomitant osteopenia and osteoporosis diagnosis, especially in grandparents or even parents if they're old enough. And measuring the actual vitamin D levels is something that we've begun to do routinely, and sequentially treating that to try to prevent the later onset of those kinds of problems. That could be with appropriate counseling about dietary calcium and supplemental calcium, as well as vitamin D or just vitamin D. And getting a baseline bone density scan approximately every 1.5 to 2 years. The more it's abnormal, the more you want to pick it up. Many radiologists will not tell you and report that there is osteopenia, but when you look at the actual results, you will see that those people with osteopenia actually exist and are more than in the general population. Osteoporosis by itself per se is pretty rare in the pediatric, adolescent, and young adult population, more in the older patients. And again, make sure that there's not asymptomatic celiac disease, Crohn's or ulcerative colitis, because that will add to vitamin D malabsorption and the consequences to the bone metabolism itself. Ovaries can show primary ovarian failure. X monosomy is the most commonly occurring sex chromosome anomaly, 1 to 2% of all female conceptions, but more than 90% of Turner conceptions spontaneously abort. Short stature and delayed sexual development are the most frequent, and in 50% of girls with Turner syndrome are the only things that show up until you start questioning them about learning and math, until you start questioning them about ear infections, until you start questioning them and looking at their orthopedic or facial or other body examinations. Most ovaries with Turner syndrome at birth are fibrous. So neonatal and infant FSH levels often are elevated as a confirmation, maybe even before you get your genetic testing back. There's some ovarian atresia in up to 15 to 25%, but it may not be as severe until adolescence or adulthood. About 15 to 20% will have some breast development. A little bit lower, 5 to 10% will have some spontaneous menarche, but then almost all of them will have secondary amenorrhea, and only about 1 to 3% have been reported as being able to be pregnant. The gonadal failure, like I said, can be seen in the newborn period and extends through about age 4 years of age. High FSH would be the classical finding. Normal, not high gonadotropins then in the peripubertal range with low estrogen levels, lack of breast development, or beginning breast development but not progression, and other estrogen effects, including lack or abnormal menses. And like I said before, if you're going to treat with growth hormone, and I hope that that will be considered, and you actually optimize growth, then there might not be a specific reason for postponing estrogen treatment. If you're further behind because there was a delay in diagnosis or delay in starting the growth hormone, or just a less vigorous effect, then you might want to consider delaying estrogen to allow the bones to stay open and allow the growth hormone to do what they're thing. If you want to consider estrogen treatment, the treatment is estrogen, and it can be with Premarin, it could be with ethinyl estradiol, it could be oral or transdermal. All of them can be used without any problem. After the first few years of estrogen-only treatment to induce menses and finish breast development, you want to reduce the risk of endometrial hyperplasia and actual carcinoma by adding progestin. And the easiest way to do that is just to switch from an estrogen-only preparation to an inexpensive birth control combination. But you can do them with separate estrogen and separate progesterone if you prefer doing that. The later the diagnosis, the often you must delay the estrogen effect to maximize the growth and keep the epiphyses open. So here's an example of somebody who presented to us at about age 7. Brooke was on the lower side, but in the normal range of height, a little bit overweight, perhaps related to that insulin resistance we talked about. Dropped a little bit by about age 5 to 6. Nobody paid attention to that. By age 6 to 7, the height was a little bit better, but now we're tracking closer to the first percentile instead of closer to the 10th or 15th or 12th percentile. And by the time they referred her to me, she was actually even a little bit lower, closer to -2%. Bone age was delayed. And here's what growth hormone did with eventual estrogen. I would tell you this was a delayed treatment. It would have been very nice to have gotten that referral way back at age 2 or 3 or 4, because she had about 10 other stigmata of classical Turner syndrome that you just heard about. All some dealt with, some ignored, some minimized. All should have been addressed with the appropriate consultations or possible treatments. So here's what it looks like. If you think about all those things in a summary form. Short stature, the treatment is growth hormone, maybe delaying puberty with oxandrolone a little bit, and then eventually adding some estrogen at some point. Thyroid dysfunction, obviously thyroid treatment either for hypothyroidism or for hyper if it's the rarer one. Celiac disease, a gluten-free diet. Bone, calcium, and vitamin D abnormalities, at least vitamin D supplements and paying attention to the calcium that's going in. Hypertension is particular treatment for that. If there's aortic or cardiology disorders, referral for a cardiac formal evaluation and consideration for surgery, depending on what those are. Orthopedic follow-up for the scoliosis, and appropriate school support and consideration for extra attention and support for the learning kind of problems, especially math. So let's switch gears for a moment. And let's talk about Noonan syndrome. What I told you in the past was called male Turners. But in fact, Noonans can be boys and girls. And you can see, I think, a few similarities and a few differences just from these typical Noonan slides that I'm showing you here. And I'll go through some of those as well. Noonan's is 1 to 1,000 at 1 to 2,500 live births, so actually a little bit more common than Turner's. Usually it is an autosomal dominant disorder, but like I said, it can be boys and girls. Primarily, the diagnosis depends on clinical features, and now we've got genetic testing available. And the differential diagnosis with similar phenotypes is Turner syndrome, if you have a girl, neurofibromatosis, and Leopard syndrome because of the lentiginous, if that's the presenting finding. Short stature, up to 83% of patients with Noonan syndrome. The congenital heart defects in the upper right they tend to be right-sided rather than left-sided. So it's pulmonary, not aortic valve stenosis. Hypertrophic obstructive cardiomyopathies can show up, ASDs and VSDs, as well as PDAs. So again, you might still get that diagnosis from one of the cardiologists who has recognized a shorter kid without appropriate cardiac pathology to explain the short stature. On the lower left, characteristic facial features: broad, high forehead, wide-spaced hyperteloid eyes, low-set posterior rotated ears with a thicker helix than is typical, a high arch palate, like we said in Turner's, small jaw, again like Turner's, high arched eyebrows, short neck with excess nuchal skin, epicanthal folds, downward slanting palpebral fissures, and low posterior hairline. So you can, having heard the stuff about Turner's, see where some of those things will begin to be very similar. The Noonan's kids can also have a sunken chest and a variety of skeletal disorders. Many of them will have undescended testicles at birth or hypoplastic testes, and that's important to pull them down so that the risk of malignancy will be easier to detect if that's what's going to happen. Lymphatic abnormalities, increased bruising and bleeding in some subtypes, some mental retardation and learning disabilities, as well as poor eyesight. So that's a big, long list, even a bit bigger than for Turner's. Now, we've got 4 different gene abnormalities that we're aware of at the moment. The most common is the PTPN11 mutation. It's a signaling pathway abnormality on chromosome 12, but it's called PTPN11 because it's a non-receptor type 11 protein tyrosine phosphatase issue. 50% of the mutations in Noonan's are like this. The classical things are pulmonary valve stenosis, short stature, and face dysmorphology in that group. The next one is the second one from the bottom, the SOS1, son of sevenless, 17%. Typical face dysmorphology, typical cardiac abnormalities observed in Noonan syndrome, but less frequent short stature, as it turns out. Not none, but just less frequent. The crass abnormalities are more severe phenotypes, less than 5%, and the RAF1 are the rest of them 3 to 17%. And that the RAF1 is especially important because that one's associated with a very unusual hypertrophic cardiomyopathy. 20% of Noonan syndrome patients don't have any obvious genetic mutation, at least identified so far, but clinical parameters may still allow diagnosis to be considered, and in this case, growth hormone because of the short stature. So here's what it looks like. Often, the neonatologist will assess newborn anomalies, and if enough of them are being paid attention to, you might get a clue even in the newborn nursery or shortly thereafter. If there's significant cardiac disease, often the cardiologist is consulted within that first month of life, if not in the nursery themselves. You might see a clinical geneticist for more specific testing. We're often, as endocrinologists, the ones who order the genetic testing rather than the geneticist in our practice. And again, the issue is to make this diagnosis earlier and earlier so that you can provide appropriate counseling, appropriate therapy when it's necessary, and consider whether the short stature should be growth hormone treated or not, and what to do about the vitamin D needs and the associated thyroid and celiac disease problems. Early weight and length are usually normal at birth, but other features may be apparent. In 63% of patients, there is some feeding disability or nonspecific failure to thrive. Like I said, the growth hormone levels are usually within the normal range, but growth deceleration starts to show up early on if you have a height and a weight that's accurately done, and if you plot it every single visit, because then that will jump out at you that the abnormality is there. In puberty, there is delayed puberty, maybe absent puberty. The growth spurt is reduced or absent. The bone maturation is delayed. The mean adult height is 64 inches, 162.5 centimeters, 152.7, less than the 3rd percentile in a West German study. And growth hormone, like I said, just like in Turner's, is used to accelerate growth and increase final height. Here's the normal range. Here's the Noonan's range. Looks familiar? Very similar to the curves for Turner's compared to the normals. Here's the indication trial for growth hormone. We follow the kids for about a year, and then we split them into a lower versus a higher dose. And then we followed them. The age range was 3 to 14. The dose was adjusted every 3 months based on weight, on a weight basis. The dose was reevaluated at 2 years, and then treatment continued until final adult height for a total follow-up of 11 years. And here's what we found. Before treatment, about 4 to 5 centimeters. 1 year into treatment, 8.6. with the higher dose a little bit higher, 10.1. So higher is a little bit better and no difference in side effects. And 2 years was not quite as good. That's true for almost all cases of growth hormone treatment. The first year is usually the best and the biggest catch-up. But you still have somebody growing 6.7 versus 7.6 centimeters at year 2. And when we normalized to final height, we didn't show any difference at the end. So even if you were a little bit late to start the higher dose, you did okay. The mean height gain from baseline, 9.9 centimeters for the boys, 9.1 for the girls. Here's an example of what that looks like in somebody who was started at growth hormone at age 9, already way below the charts. Notice that the pediatric data already was there at age 7 and at age 5.5. The chromosomes were normal in this girl, so it wasn't the Turner syndrome. And this was a PTPN11 classical 50% mutation. Not quite as low as the first guy. Alexander was hanging around the 1st to the 2nd percentile, maybe with a little drop off between age 6 from age 4, or maybe just measurement sloppiness. Predicted to end up at -2 something standard deviations at below the 1st percentile. The mid-parental that you see in that purple up on top was about the 60th percentile, so significant less than what you would expect from that family. And here's what Alexander looks like, rather consistent, heading right towards now where the mid-parental estimates should bring him. Here's Brandon, again, looking very similar to the ones I showed you. Fall off from age 2 to age 4, unrecognized by the PCP. Following along that low percentile. Again, a little drift that adductor is real, a little bit upward and a little bit downward then, and then a little bit further downward by the time they come to see me. This is a person who came to one of my lectures and said, "Oh, I've got a patient who's just that. I've been wondering what's been going on." And here's what Brandon looks like. And again, look on the left-hand chart, the predicted final height when we started pre-treatment was less than the 2nd standard deviation and should have been closer to the 55th by parent's height. And now we're getting up closer to the 25th to the 30th percentile, but we still have longer ways to go. And I can tell you that I didn't plot this out, but Brandon, in fact, beat his parents. He ended up at about the 75th to 78th percentile. Now, how about Marissa? You can look at her face and see a whole bunch of things that we've already outlined. The big forehead, slightly hypertelorism, smaller jaw, maybe a little bit of a web neck. She had also a whole bunch of non-specific things going on that pointed to either Noonan's or Turner's. We weren't quite sure. Her genetic studies turned out to be negative. She didn't have Turner's. She didn't have any of the obvious Noonan's one, but remember, there's a small group that don't have those abnormalities that we haven't yet identified. But she clinically appeared to have that. And here's what she looks like, way below the percentiles with delayed bone age and staying rather consistent, maybe with a smidge of a catch-up, or there was an error in measurement or plotting there. And here's what Marissa looked like, being treated for about 7 years. If you want to look at the comparison, Noonan is not gender specific, boys and girls. Turner's is obviously an abnormality of the 2nd X chromosome, so females only. The 4 genetic mutations are as listed, and as you heard, for Noonan's with PTPN11, the 50% of them. And you could have complete absence, partial, or complete missing 2nd sex chromosome. in Turner's. The congenital defects are not 100%, but mostly right-sided for Noonan's and mostly left-sided related for Turner's, so slight differences. Short stature, very significant for both of them, with an excellent response to growth hormone and eventually puberty replacement in Turner's. Puberty is often delayed. That's actually a good thing for final height for Noonan's, but maybe need to be addressed and followed. Puberty for Turner's is not 100%, but often absent. And like I said, it can be a little bit and stop in all kinds of varieties. There is potential spermatogenesis failure, particularly if there's undescended testicles that haven't been brought down. And there's malignancy potential for that as well. The girls and the women eventually will have ovarian failure almost uniformly, but again, not 100% because a few of them have gotten pregnant. So I think that's the last of the slides. And I think we have a little bit of time for some questions. It looks like there's some in the chat, so let me open those up.
Thank you, Professor Stewart, for that great presentation. We are very happy that you have taken us through this. Maybe we have been looking at the short boys and short girls and thinking maybe there is a problem, maybe we think it's something else, maybe we think it is malnutrition. I want to go through some of the questions that are there in the question and
okay.
I won't answer the questions of Jeremiah. I think somebody else can answer those questions. But Dr. Brenda Oemba has asked, are there any risk factors for Turner syndrome?
Not specifically, because it's not inherited in that way. It's an abnormality of that second X chromosome, and that there's sometimes some implication in some studies that it might be a little bit more the father's X chromosome rather than the mother's. But the real answer is not at all. It's not going to be inherited in that fashion. But the diagnosis risk factors are not paying attention to one of those 15 or 20 different things that can show up. And if you had just one of them, not so obvious. But when you start to see 2 or 3 or 4 of them clustered together, and it's bad enough scoliosis, or it's nevi and keloid formation in a short kid, or there's these non-specific odd face appearances or webbing, cardiac abnormalities in that same subgroup, get a genetics consult or order the actual chromosome studies yourself. You'll make the diagnosis. And like I said, we often, when I go out and give these lectures, I come back because I tell the typical pediatrician, if you have a typical practice, and let's say you have 5,000 patients, you should have 2 Turner's patients. If you don't know who they are, you're missing them. Go find them. Make the referral. Listen to what I said and pay attention to those kinds of patients. Next question.
Thank you, Prof. The next question is from Ruth Guiri. After how long should hormone replacement be stopped in Noonan syndrome?
The real answer is when you get very close to final height. It's not growth hormone deficiency where you have to consider growth hormone replacement as an adult for metabolic reasons. So there's no reason to continue that. There would be reason to continue it if you had thyroid disease, because that doesn't go away. There would be reason to consider the vitamin D aspects of things for both Turner's and Noonan's, because that doesn't go away. Although you might get it better if you had some more exercise, for instance. But all those are not related to the growth hormone specific question. So you stop it when you get to final height, actually, for both of them are very close to final height. You would determine that by the top part of the curve that normally slows down when you're getting low and lower height velocity. If you've had to make replacement with testosterone for a boy with Turner's because they've had hypogonadism. You're following the same kind of parameters for bone age, for testosterone levels, and the same thing when you reach no more height gain, that's when the growth hormone should be stopped. It doesn't have to be stopped. You generally finish what supply you have and don't order it again.
The other question is from Phoebe. Kindly share your experience, if any, on Turner's or Noonan syndrome and diabetes. I think the reason why she's asking is because you had talked about autoimmune diseases in Turner syndrome. Do you find more this patient with more type 1 or type 2 diabetes in this one, and which one?
The Turners, even though they have more autoimmune thyroid disease and autoimmune celiac disease, don't have much more type 1 diabetes. We don't have a good explanation for that. They mostly have insulin resistance and glucose abnormalities even before they have overt symptoms, and sometimes don't have any symptoms at all, just the whole conglomeration of the glucose intolerance that is the precursor to type 2 diabetes. If they're more overweight, like anybody else, that's a little bit more tendency to show up earlier. But you don't have, like, if the answer to this question is, it's not type 1 that we're seeing very much of.
The other question is on when do you do orchidopexy in this patient?
Earlier is better than later. Some people like to wait until you're out of the frank newborn period. Some people like to do it then. We have recommendations that have been kind of talked about it in round table, but we don't have as good specific studies to see different approaches to that. In general, the sooner you do it, the better it is, because if there's going to be an abnormality, it's generally not going to show up until later in puberty or even early adulthood. And you're talking now specifically about the boys, obviously with Noonan's, but that's in general for everybody. The more you know where the testicle is, the better you can see if there's going to be an abnormality. And those can be cysts, those can be
there is somebody
benign lesions, or even become malignant.
There is somebody who is, I don't know, who is saying that you give in Turner syndrome and Noonan syndrome, you give growth hormone without checking the levels. I think before you make the diagnosis of Noonan and Turner syndrome, one of the tests that you have to do is growth hormone. I don't think
that's not true, because both of them are not growth hormone deficient syndromes. You might want to check an IGF because you're going to follow that to help you with dosing. You're going to, just like you're going to follow the weight, it's going to be a per kilo dose. We have new growth hormone preparations that are weekly injections instead of daily injections. So that helps a little bit with compliance issues, but you don't need it for insurance in most of Europe and Japan, Korea, Australia, New Zealand, America, Canada. The insurance companies have now understood that there's good catch up, there's improvement in quality of life, and there's better health outcomes in general if all these things are paid attention to. And you know, same thing. I've been the one that often makes the diagnosis as an endocrinologist because I'm seeing them every 3 months to track their growth and see if their doses need to change. And if I start to pay attention and ask questions about bowel function, and I'm looking at antibodies, especially if there's already thyroid antibodies, I'm going to look at the transglutaminase antibodies as a marker. I'm going to pick that diagnosis up way earlier than somebody who's not paying attention to any of those things, as is often the case.
There is somebody who has commented here, but I think what you told us is that these patients are usually given growth hormone until they have reached a certain bone age. Then at that bone age, that's when you introduce the sex hormone. There's somebody here who is who is saying that estrogen hormone replacement in Noonan syndrome, especially not growth hormone. I think Prof had said the other way around. You do both, but one before the other. Prof,
well, if there is already going to be a delay if I want to have some more catch-up growth because there's been a big delay, not an early starting of growth hormone, if I start the growth hormone early, I can start puberty pretty much on time. If the height is not where we want it to be for any reason, non-compliance, later starting of growth hormone, or just a less than average response, right? Then we're going to have a conversation as we enter middle years where puberty starts to show up. We want to say, gee, if we delayed puberty, I can give you something that turns off, if you're male, your androgens from any place. I just block the androgen effect for a few years. That's going to keep your bone age from closing faster. Therefore, you're going to have a longer time for the catch-up to continue to reach a better height. Not everybody will agree to that, but if you talk about it like that and have an open conversation and you're paying attention to their emotions with this, some kids are going to get teased because of the way they look, right? Some kids are going to get teased because they got 5 or 10 different chronic things to deal with all at one time, including how they do in school and what extra help they need in school. Some kids will get teased just because they were short for a longer period of time. The later I start the estrogen for the girls and the later I start the testosterone kind of effect for the boys, if that's needed, the open epiphyses will allow for the growth hormone to continue to give us positive effects. But it's a conversation with the parents, it's a conversation with the kids as they're maturing. If you develop a good positive relationship and you allow open discussions of these things and don't judge them, you can have the conversation, and 90-something% will say, yeah, that makes sense to delay it a little bit. I'd rather be an extra 2 centimeters or 3 centimeters if I have a choice. There's no side effect for that, except I continue my treatment, and then I'm going to finish up puberty, even if you're not doing it by yourself.
The Turner syndrome, they are going to be given the sex hormone and the growth hormone to give them height, and also to help to establish their breast enlargement. And for the boy, right, for the Noonans is to get them to get to the height. I can see there are different people asking different things, but the thing is that the Turner syndrome will not, especially when they are pure Turner, not mosaic, they will not be able to produce the estrogens for themselves. So that means they will need to be supported with the sex hormone, most likely for life, to be able to remain the way they want.
That's right. And if they need to, that's right, if they're the rare Turner who has, some puberty by themselves, then you want to know something about LH and FSH and estradiol. You want to know something about dihydroandrostenedione sulfate coming from the adrenals or the gonads. And you want to pay attention to the fact that over time, as they get older, they still might have some ovarian failure because that's more common. But there's so many different varieties. You can't answer that question in a very simple way, except to pay attention to the patient, to the symptoms, to the clinical findings, to what lab tests you have, and be open to trying to figure out and sort those kinds of things out. The boys are a little bit different. If they are low in testosterone because they have an abnormal testicle that's not capable of making testosterone, they also might need that for life. If they're just delayed without being hypogonadal in a very significant way, they might, in fact, in an individual case, just need a little bit of a boost and then not need it. But again, it's going to be very individual, and you're going to know that by watching what you've done, how they've responded, what happens to the pituitary gonadal axis with your hormone levels, what happens to their physical response to your medications. But both of them won't need growth hormone because they don't have growth hormone deficiency. They've never had growth hormone deficiency. The growth hormone is treatment for the short stature that's caused by the syndromes themselves.
Prof, you can give us maybe from your experience, if you have the Noonan syndrome boys, if they are given the growth hormone, they are supported with sex hormones, if they ever manage to get children, will the children have Noonan syndrome?
Well, we think it's an autosomal dominant abnormality. So they've got a, autosomal dominant down to the next person, right?
Yes.
And if they have sperm abnormalities, they may not be able to produce sperm. So that may be a separate problem. But if they're making sperm, they got a 50-50 chance of passing that along. Depending on the gene passage, right?
Yes.
You could, in theory, you could do intrauterine sampling and test that fetus and see what's going on. You might be able to detect some of those abnormalities on a prenatal examination with some scanning devices, but they're not all that apparent all the time. But if you got a sample from the fetus, you can look for any of those things, especially if you know what the father passed along, or if it came from the mother's side, the mother passed along.
But Prof, but I want, in Kenya, the cheapest growth hormone maybe we can get is around between 20 to 30,000 per month. If I get a child with Turner syndrome or Noonan syndrome, and they can't afford growth hormone, which is not usual for people to afford that kind of treatment, what do we do? Do we just wait until they are 12 years by born age, and then we give them the sex hormone, or what advice do you have for us?
If you're not treating Turner's, making the diagnosis, like I said, allows you to take care of those other 10 or 15 concomitant abnormalities. So you're doing some things that are important for just making the diagnosis to start with. If you're not able to afford or have some NGO help you, or have an insurance company that will pay for that, or the government, if it's health insurance from the government, then you don't have an option. But you still need to think about what you're going to do for finishing or even starting breast development, and for getting the ovaries to function like the rest of the women in society, because most people will prefer that. There may be some people who say, no, I don't want to do that, but estrogen has other benefits besides just feminizing and menses. It has positive effects on bone metabolism and osteopenia and osteoporosis risks. And if you didn't treat them, they're going to have more osteopenia, more osteoporosis earlier, because they don't have estrogen to help with the bone metabolism.
Have you seen any family where they have two children with Noonan syndrome or with Turner syndrome in the same family?
Never. It's not so common, but the Noonans would be a little bit more common. Most people, if they have a child where this is going to be passed along, the Turner's is kind of an accident of nature. And so it doesn't automatically show up because it's that accident that happens to the X chromosome someplace along the line. Whereas the Noonans, if it's a dominant passed along, you got a 50-50 chance that the next child will have that. They might decide not to have children, or to have, if you know where the gene is coming from, to have artificial insemination.
And maybe to finish, you can tell us about the plastic surgery that you can do on this patient. In our setup, the earliest we do maybe during infancy, and or maybe when their patients are under 5, we usually try to reduce the redundant tissue at the neck. What do the people in US do?
Most of the time, the neck is not a big thing. It's more of a nuisance thing. The same thing with the funny, hair that's turned up. You just got to, you got to do some special things, and maybe you need a little bit more hairspray to keep your hair behaving, or a slightly different hairstyle. The orthopedic things, some of them are correctable. Scoliosis might be severe enough. Kyphosis might be severe enough that you need bracing or surgical correction. Same thing, if you pick it up earlier, you might be able to get along with braces rather than surgery, and that's will save expense as well as hospitalization time and pain. The nails, you don't have to do much of anything except just be aware. The keloids, you want to pay attention, and the nevi, to make sure that you're looking for fast growth and changes like any nevus, because that can mean malignancy potential. The gonads for the boys that are undescended, you want to bring them down if they don't drop by themselves after a period of time, and you can follow the standard routine for that the urologists are doing in your area. What else? The cardiac things, again, will depend on what the specific cardiology function is at the time. And the cardiologist and the cardiac surgeons will have standard protocols. There's no different outside risk for that other than what the abnormality is of itself and how severe it is. The hypertension is regular treatment for hypertension. The learning disabilities are, straight, ADHD treatment if it's hyperactivity. If you need more help with math skills, get more help with math skills. Know where it's coming from, because that's what Turner's will show up with. So just pay attention to all those kinds of things. Be aware of the anxiety, be aware of the increased depression, be aware of the teasing and bullying, because if you talk about those things, you can get them to be addressed earlier. You can get the psychosocial support going. You can get the referrals made to the specialists that are needed, whether it's in school or psychosocial psychologists, psychiatrists, etc.
Thank you, Prof. This has been a very great webinar with you taking us through these two syndrome. I know we have them we have quite a number of Turner syndrome, and I think Noonans are mainly usually missed. But I think with this topic that you have taken us through, I think we will be able to pick them because they are out there and we are missing, and because we know they are more common than Turner syndrome. That means they are there in our setting. They are common in our set. I think with this now we will start getting more of these patients. I
hope so, because that means you're finding them. Go out and talk to the pediatricians, talk to the school nurses. You can do these kind of talks with the school nurses because they'll find those kids just as well as the pediatricians and the general practitioners, and the health aides will find them.
Thank you, Prof. At this time, I would like to call on Dr. I don't know whether Dr. Priska, you are there to address the people they are talking about the CPD points being removed from their portal. I don't know whether you have seen. There is somebody called Anonymous. I have no idea who it is Anonymous. I don't know whether it's one person or there are many people. So Priska, would you like to comment about the CPD points as you give thanks to Prof?
Thank you. Good evening. Thank you very much, Prof. Stewart.
You're welcome.
And Dr. Mugai for that very insightful discussion on Turner-Noonan syndrome. With regard to the CPD points, there will be emails. Those who are asking about the CPD points will receive email communication regarding the same in due course. So check, look out for your emails. And then there are also questions about availability of the presentation. With the Prof. Stewart's permission, we shall upload the presentation on the KNH YouTube research channel in the coming days.
Absolutely.
Thank you. Thank you. So I think with that,
and
yes.
report back to me how many more you found. Okay,
we will.
There is this question, Priska, to the University of Nairobi research team. There is a problem at the KEMPDC ICPD portal. CPD points that have been uploaded have been removed and points deducted. Please assist.
Yeah, I think the KNH research team will respond to that to those who have been affected by email. They will need to probably investigate on that.
Yeah,
thank you.
The anonymous has a name, and because you look for the person with their email. Thank you very much for everybody for attending this session. It was great having you online. Thank you.
Thank you. Have a good night.
Bye-bye.